right, good morning. Welcome to In the Trenches with David A. Cohen. I'm going to be talking about diabetic emergencies, and I'm going to focus on DKA. This is a common problem we see in the inpatient service in medicine. And I'm also going to mention HHS, hyperglycemic hyperosmolar state, used to be called HHNK. So, patients presenting with DKA, they're usually type 1 diabetics. However, it could be a type 2 diabetic, so it's not 100% type 1 diabetics. And often in type 2 diabetics, they develop DKA if they have a sudden change in their blood sugar. So you kind of have to understand the physiology. What does insulin do? Insulin is going to inhibit glycogenolysis. It's going to inhibit gluconeogenesis. It's going to increase glucose uptake by cells, the muscle. It's going to inhibit proteinolysis. And it's going to inhibit lipolysis. It takes a lot less insulin to inhibit lipolysis as related to the other actions, period. That's why patients with type 2 diabetes often have enough insulin to prevent lipolysis and diabetic ketoacidosis. So, diabetic ketoacidosis, type 1 diabetics, and the most common cause is probably non-compliance with insulin. Often these are younger people, and for whatever reason, they're not as compliant as they could be. Other things, you have to make sure nothing's precipitating this, like an infection or an MI or any other stressful situation on the body. But with DKA, you can get two types of symptoms. You're going to get symptoms due to hyperglycemia and symptoms due to ketoacidosis. The symptoms due to hyperglycemia are polydipsia and polyuria. And the symptoms due to DKA are dyspnea and nausea and vomiting. So let's talk about these. So people with high blood sugars are going to have polydipsia because they have increased osmolality, which is a strong stimulator for thirst. If you calculate the formula for osmolality, equals 2 times the sodium plus glucose over 18 plus the BUN over 2.8. Normal serum osmolality is 280 to 295. Okay, if your glucose goes up, you're going to be thirsty. That's the mechanism of that. Okay, why do they get polydipsia? Polyuria, sorry. That's due to an osmotic diuresis from the high blood sugar. So polydipsia, polyuria. Now it should be noted that the patients who have really high blood sugars, who are not DKA, we used to call this HHNK, hyperglycemic hyperosmolar non-ketotic state. Now it's called hyperosmolar hyperglycemic state. These people often cannot express their need to drink or their symptoms. They could be demented. They could be people who are stroke patients who are nonverbal. Sometimes these patients are on parenteral feeds and they're not being monitored. But often these patients, they're impaired in some way and they could not express their symptoms. Now, DKA, you're going to come in with a lower blood sugar because they're going to be symptomatic earlier. And here's where you take biochemistry from first year of medical school, the Henderson-Hasselbalch equation. So, at all times, people want to maintain pH as close to normal. And if this goes up because you're in DKA, okay, and you're acidemic, you want this ratio to go down. Now, the ratio could go down 2 ways. You either lower the PCO2 or you increase the bicarb. So to lower your CO2, you're going to hyperventilate, and these people are going to become severely short of breath at times, and they're not going to know what to do. They're going to go to an emergency room. They can't breathe. Or to generate bicarb, acutely to generate bicarb, you're going to vomit. It takes about 48 hours for the kidney to compensate, and these people are going to have nausea, vomiting, abdominal pain. Oftentimes, they come into the emergency room and they could be suspected of having an acute abdomen, and sometimes the surgery staff are the people who are the first ones called. But these patients have symptoms. They have symptoms. Okay, so that's how these people present. Now, in diagnosing DKA, obviously you're going to get blood work, and blood chemistry is going to show a low bicarb, and you're going to have an increased anion gap. And the sodium is usually low. If your glucose goes up, for every 100 your glucose goes up, your sodium's going to go down to 1.6. So this is hyponatremia with increased osmolality, as opposed to decreased osmolality, which most causes of hyponatremia have. And at times the potassium can be a little elevated. Why is it elevated? Okay, you have decreased insulin, you have increased osmolality, sometimes acidemia, although more with inorganic acidosis. These things all cause intracellular shifts. And sometimes these patients have underlying renal disease and possibly a little type 4 renal tubular acidosis. And you're going to get a urinalysis. Now, there are two major keto acids. Acetone's a ketone, but not a ketoacid. Beta hydroxybutyrate and acetoacetate. If you get a urine dipstick, it's just going to dip for acetoacetate. Beta hydroxybutyrate will not turn it positive. And oftentimes these patients are in a low redox state. They're volume depleted, and they're putting out beta hydroxybutyrate, and the acetoacetate is not registering. And as you correct them, as they get better, the urine could turn progressively positive. It doesn't mean that they're getting worse. And now we also, and this over the past 5+ years, we're able to measure serum beta hydroxybutyrate levels. That's how you diagnose this. Now, if the patient's very sick, okay, if the patient is very sick, then you might get a blood gas also. You don't always need a blood gas, but that will tell you where you are. And you also may need to assess the acid-base state. Okay, now sometimes with a lot of vomiting, they could actually be alkalemic, and there's a term that's sometimes used, diabetic ketoacidosis, where they have a DKA and they're just vomiting so much, they actually become alkalemic. Okay, so real quickly, how do you treat these people? Obviously, you're going to be very aggressive with them. The first thing you're going to do is give them IV fluids. You used to give normal saline. I guess lactated ringer is a more balanced solution. And often when you give normal saline, you're going to go from an anion gap metabolic acidosis to anagma and normal anion gap metabolic acidosis. But by giving fluids by themselves, you're going to do three things. You're going to dilute the glucose. You're going to increase renal blood flow, and you're going to urinate out more glucose, excrete it, and you're going to decrease counter-regulatory hormones. This would be catecholamines, glucagon, cortisol, and growth hormone. And this in itself, by lowering them, you're going to lower the sugars. But obviously, these people, besides fluids, and they're going to need fluid, are going to need insulin. And you're going to, normally, it's not all the time, but for all practical purposes, you're going to put some patient on an insulin drip. You're going to give them a bolus to bind to receptors, okay? And then you're going to, you're going to put them on a drip and you're going to titrate it, but it's usually like 0.1 milligram per kilogram per hour. And you're going to titrate the glucose, okay? Now, the most important thing with doing this, you have to watch the potassium. People have died from this reason. These people, you could admit them, check finger sticks, they're getting better, and all of a sudden, the patient goes into cardiac arrest. When you're taking glucose intracellularly, you're going to take potassium in with it. So you have to keep very close contact. And even if their potassium is high, you're not going to treat it. It's going to go down with the glucose. And if the potassium is not elevated, you're going to want to have potassium in the IV from the get-go. Sometimes you're going to correct the hyperglycemia before you correct the ketoacidosis, and in that case, you have to add D5 to the IV. You know, otherwise, if you correct the sugar too quickly, you could cause brain edema. So you need to have this balance. Usually, you know, they're going to correct at the same time. And then you're going to transition them to basal bolus insulin. You may or may not have the endocrine service involved. Often the type 1 diabetics, you're going to put them back on the regular insulin dose, and the type 2 diabetics may need transiently to be on insulin. And with this, I'm going to stop. Thank you.